Good morning to all. Initially, I would like to thank ESGE Days Scientific Committee and both chairs for the kind invitation to present our results in this session. I will present data from 11 international tertiary referral centers included in our recent retrospective analysis of gastric neuroendocrine neoplasms treated with endoscopic submucosal dissection. My name is Nikos Lazaridis. I work in Royal Free Hospital in London and have no conflicts of interest to declare. As we know, gastric neuroendocrine neoplasms represent the most frequent digestive NEN type and are increasingly recognized nowadays due to expanding indication of upper gastrointestinal endoscopy and heightened awareness from both endoscopists and histopathologists. Nevertheless, optimal endoscopic management is still to be determined. Gastric NENs are often silent and benign, but lesions larger than 2 centimeters and type 3 NENs could be more aggressive and present malignant potential. There are not enough data regarding the effectiveness and safety of ESD for gastric NENs. Thus, we decided to retrospectively review all ESD procedures for gastric NENs that took place at 11 large tertiary hospitals from 2010 to 2020. Baseline demographics, tumor characteristics, and peri- and post-procedural adverse events were recorded. ESD overall efficacy, R0, and recurrence rates were also recorded. R0 resection was defined histologically as clear lateral and vertical margins. In total, 73 procedures were performed in 69 patients. The size of the lesions ranged between 6 and 30 millimeters with a median size of 12. 23% of them were ulcerated at the time of the resection. 56% of patients had more than one lesion identified in their stomach. Atrophic gastritis was present at 82% of cases, and 9 patients were diagnosed with active Helicobacter pylori infection. 61 lesions were classified as type 1, 11 as type 3, and 1 as type 2. After histopathological review, 59% of cases, so 43 lesions, were classified as G1, 34% as G2, and 7% as G3. The majority of the lesions were located at the proximal and distal part of the stomach. Endoscopic en bloc resection was recorded at 90% of the procedures, while in 8 cases, en bloc complete resection was not feasible. R0 resection was verified after pathology review in 75% of cases. Specifically, R0 lateral margins were seen in almost 88% of cases, and R0 vertical margins were seen in 79% of cases. Additionally, there was a positive lymphovascular invasion noted at 12% of all cases. The majority of the procedures were performed by conventional ESD, and 33% of them, meaning 24 cases, were facilitated by pocket creation method or saline immersion therapeutic endoscopy, which is a variation of the pocket creation method. The mean procedure time was about an hour, and there were 9 cases with intra-procedural complications. Those were mainly bleeding, and in 1 case perforation, and they were all treated endoscopically without any further problem. There was no delayed post-procedural adverse event documented. Additional treatment was proposed in 3 patients after R0 resection, and 2 of them needed surgical management. In another 2 patients, additional treatment was offered when lymphovascular invasion was seen after R0 resection. The mean follow-up time was about 35 months, and all patients had at least 1 follow-up gastroscopy after initial resection. At follow-up, 5 cases of recurrence were identified, all in patients with initial R1 resection, and 1 of these patients needed additional treatment. Finally, we concluded that ESD for gastric NENs appear to be safe and effective and provides very accurate pathological review and curative treatment for our patients. Nevertheless, careful selection of patients is needed, careful selections of lesions to be treated is needed, and these decisions should be taken after thorough assessment and multidisciplinary team review. Thank you very much for your kind attention.